Okay, well, we'll get started here as people continue to trickle in. First off, thank you everyone and welcome for coming to today's presentation, Assessment of Decision-Making Capacity. Can the patient decide? We're gonna get some really great information from Ellen and learn a lot today, so it's gonna be great. Just quickly, I wanted to let you all know during the presentation, your cameras will be off during the presentation, along with your microphones will be on mute. However, if you have questions, please use the chat feature at the bottom of the screen. And towards the end, we'll have a smaller group today, so we're able to unmute anyone that would like to take themselves off of mute and ask any questions directly to Ellen. I'll ask the questions or moderate them at the end of the presentation for the Q&A towards the end of the presentation. Quickly, I'm with Belmont Village, Lincoln Park. We're a senior living community in the heart of Lincoln Park. We have assisted living and memory care, and we actually have two levels of memory care. One is a traditional secured memory setting, and the other is for folks with mild cognitive impairment, early stages of memory loss, where they live within our assisted living, but they participate in programming that helps stimulate the brain and provides a routine for them 8 hours a day, 7 days a week. Would love to tell any of you more about that and all of the COVID protocols, of course, that we have in place if you have questions. But I'm actually going to turn it over to Linda to introduce herself and get Ellen started. So Linda, take it away.
Hi, how are you? Thank you so much for having us, Lauren. I'm Linda Dronsky with Seasons Hospice and Palliative Care, and I'm one of the hospice care consultants. And gosh, Seasons has been around in the Chicagoland area probably, I want to say 22, 23 years, I'm forgetting. And we are active in 19 states at 27 sites. And here in the Chicagoland area, we provide hospice and palliative care, those end-of-life care to individuals that are appropriate for hospice. And we have a coordination of music therapy that's added in. We have our legacy program. We are a level 4 for our We Honor Veterans, as well as we have 4 inpatient units in the area. So we have a inpatient unit for symptom management at Swedish Covenant up north. We have one at Holy Cross Hospital on the south. We have a standalone unit in Naperville, and then we also have a inpatient unit at McNeil Hospital as well for end of life or symptom management. And we are, yes, happy to have Ellen, who is our clinical educator regarding the subject of assessing decision making capacity. So I'm going to turn it over to Ellen.
All right, well,
before Ellen starts, so sorry. I also want to say, if you're here for a CE credit, of course, that is something that you can get today. And Ellen will actually follow up after this presentation with these slides and evaluations so that you are able to complete the evaluation and get your CE credit. So you can email Ellen directly, and I will chat her contact information right now as well. So now Ellen can take it away.
Okay, thank you. Thanks for partnering with us today and organizing this and setting this up. And thanks to everybody for taking time out of your day to learn about assessing for decision-making capacity. Ellen Hoekstra with Seasons. I'm a certified hospice and palliative care nurse. And my role, I've been at Seasons for 13 years, is really to just educate our healthcare partners and the community. So I have the best job in the entire world because I get to talk to folks like you every day. So we're going to go ahead and get started. And there's some criteria here, and I do have the RSVP sheet. But as Lauren said, I am offering this for CE credit today. So at the end, my email will appear. I have all of your emails, but if you could just shoot me an email to let me know that you need a CE, and then I can respond with the copy of the PowerPoint and activity evaluation. And then once you complete that evaluation, I will send you your CE certificate. We're offering CE for RN, LPN, licensed nursing home administrator, and social workers. And so I have to declare that I'm an employee of Seasons Hospice and Palliative Care. We are partnering today with Belmont Village, and and I thank you again for that. And I do not have any conflict of interest. So our objectives today, we're going to distinguish between capacity and competence. And while I'm looking at myself, I'm going to minimize myself because I don't like to watch myself talk. All right, but you're going to acquire expertise in decision-making capacity. I'm very confident of that. We're going to look at decision-making capacity in the broader context of informed consent and advanced care planning for older adults, and really understand how patient and family decision-making at end of life is affected by decision-making capacity. And I will tell you on a daily basis, when we meet with our patients, we are assessing for decision-making capacity. We have a legal, ethical, and moral responsibility to make sure that our patients who are signing consents to come onto hospice are understanding what they are doing and understanding the transition from curative treatment to what people call comfort care or the hospice level of care. We take that very seriously. So here is a non-serious picture. I think you will love this. I absolutely love this. We wish all decisions were this complicated, right? Which color lifesaver that I'm going to choose. So I'd like to start this out with a case study. And so I have Mrs. Snow, which is very timely for this time of year, even though we don't have snow. So I want you to listen to this case scenario, and I'm going to be asking you a few questions here. So I have a 72-year-old woman. She lives alone. She's suffering from frostbite of both of her feet. They're both gangrene when she arrives to the hospital emergency room. Her surgeon feels it's necessary to amputate both her feet to save her life. Her chance of survival is 50% with surgery, and it's only 5% without surgery. Mrs. Snow refuses surgery, stating her feet are getting better. So with this limited information, do you think Mrs. Snow has decision-making capacity? So think about that for a moment. And I'm going to give you the answer. Should we allow her, to continue to refuse surgery? And I would say we need a whole lot of more information on this and on Mrs. Snow. And we need to assess her decision-making capacity. So I go in and I have a conversation with Mrs. Snow, and she appears intelligent, lucid, has a great conversation with me. She's articulate, she's alert and oriented. She does not want to die. She lets me know that, but she wants to live and keep both of her feet, which we know from the surgeon's perspective that would be unrealistic. She refuses to accept the black tissue on her feet as dead tissue. So I want you to think about, again, should we continue to allow her to decline surgery? And I think we all are on the same page, I hope, and we really need to assess her decision-making capacity. So autonomy is a very, very important ethical principle here in the Western world, in the United States. Really important for our patients to make their own decisions. And I think all of you know there's so many decisions at end of life and so many words. You can see all these things up on the screen that our patients and families really don't understand very often. Pulse form, I want euthanasia, I don't want morphine, life-sustaining treatments, feeding issues, and so on and so forth. But we all have the right to make our own healthcare decisions. Some call it the right to self-determination and respect. And the associated concepts I think about when I'm talking about autonomy and decision-making is informed or valid consent. And I will tell you, when I went to nursing school like 30 some odd years ago, informed consent was just drilled into our heads. Truth telling, and you'll hear us talk about in hospice, we're about truth telling. It doesn't have to be harsh, but again, our patients have to sign consents if they are able to in order to come on to hospice. Certainly confidentiality and the right to refuse medical treatment. The corresponding duty we have is not to interfere with the autonomy of others. However, we want to protect those who maybe don't have the ability to make their own decisions. So I love this quote, and I will tell you, this is from, I want to say about 1914, from a Supreme Court Justice Cardozo, and it says, every human being of adult age and sound mind has the right to determine what shall be done with his own body. And hopefully everyone here on the call today feels this way. This is our right, that we can determine what shall be done with our own body. And again, today I'm talking about decision-making for healthcare. I'm not talking about finances, I'm talking about healthcare decision-making. So, which we abbreviate here, decision-making capacity. I put this in 10 myths about decision-making capacity. I'm not going to read you each one of these. We're going to go through them. What I can tell you on decision-making capacity, though, when you Google this topic, there's not a lot of books. There's not a lot of information or articles. There isn't one gold standard that everyone uses. And that's because it's a clinical decision. It's a clinical assessment from those clinicians, meaning your attending physicians, and they assess for us the decision-making capacity of a patient. So in our state here in Illinois, our attending physician has the ability to make the decision about our patients having decision-making capacity. When we talk about competency, we are talking about courts making those decisions and not clinicians. And we look at not only their healthcare decision-making, but all of their decision-making. So myth number one, decision-making and competency are the same. They are not. We myth busted that one. All right, myth number two, lack of decision-making capacity can be presumed when patients go against medical advice. And we shouldn't conclude that patients lack decision-making capacity just because they go against medical advice. We see patients all the time who may be diagnosed with cancer, stage 4 metastatic cancer, and they have decided not to take treatment. And maybe the clinicians are saying, you know, we could try this and that, but again, they don't want the treatment. I can't conclude they lack decision-making capacity just because they're going against medical advice. The concept of autonomy requires that the patients have the right to make their own health care decisions. However, we have a responsibility to make sure that the patient does have decision-making capacity and that we've presented all the information they need to be able to make a decision. All right, so here's the model that I like to use, and this comes from legal standards for competency. And the first thing is communicate a clear and consistent choice. So when I go in to see a patient to sign up for hospice, do you want hospice or do you not? You know, just kind of asking that particular question. It's a yes or no. Can they understand the relevant information? And this is really important as they're transitioning from, again, curative care, where they're going to the hospitals, to comfort care, where we're not doing any aggressive treatment. So can they understand that information and appreciate that and apply it to their own situation? So what I hear is often, I'm tired of coming back and forth to the hospital. I just want to stay home with my family. So they're kind of asking for that comfort care. And can they reason through the information in a rational manner? How did they come up with that? You know, who's helping with those kind of decisions? And again, applying those consequences. So what if you don't come to the hospital anymore for that chemo? Well, you know, the doctor said maybe I won't live as long, but I'm going to be able to stay home with my family. So that's the model I use. And at the end of the presentation, we'll go through this model and a checklist that I like to use. All right. There is no need to assess decision-making capacity unless patients go against medical advice. So just as we should not presume that incapacity, when patients go against medical advice, we should not overlook capacity in patients who go along with everything. And I'm sure all of you might have encountered someone who just nods their head yes to everything. Well, to me, I need to step back because I don't think that's informed consent when they're not saying anything and they're not answering my questions, but just nodding their head yes, because I need to go along with whatever, the doctor or whatever is recommended. It's really important to assess patients who have certain medical conditions or those at risk for cognitive impairment. And we'll kind of look at those patients. And certainly, we really need to assess decision-making capacity when there is such a high risk versus the benefit. And we'll look at that ratio. So decision-making capacity is task specific. So higher stake decisions require a higher level of decision-making capacity. And I have an example of this for you coming up. They're time specific. So can this patient make this decision today at this time? This is when I'm looking. Today at this time, can they make this decision? Is it logical or in alignment with the patient's goals and values? So if I'm your attending physician and you've seen me for the past 20 years, I probably understand your goals and your values. And I can probably understand when something comes out of what I expect you, to want. It's really challenging, I think, when a patient comes into the emergency room and we are not familiar with them. They may not have an attending physician, and we're not sure about their goals and their values. Consistency is a must. So every time I go in that room, I want to hear the same answers to those questions. I don't want to come in, yes, I want hospice. I go out to make a copy of something. I come back in and they have no idea what we just talked about. That makes me kind of uncomfortable. So I want that consistency. So this is the risk versus benefit ratio. And again, as I said, certain decisions take a higher level of decision-making capacity. So we have these situations where they're a low risk procedure with a very high benefit, right? But then we have a procedure that's very risky with a low potential outcome. So the reason why this is a clinical decision is because there's so many different components to this, and you have to take each patient and each situation very individually. So when do we assess for decision-making capacity? We talk about at-risk patients or the at-risk decision. And when I think of the at-risk decision, I think of quote unquote, the wrong decision. So the medical community is recommending something and the patient says absolutely no. So again, we want to look at decision-making capacity on those patients. So who are our at-risk patients? Well, certainly our Alzheimer's and dementia patients. And we're going to kind of look at a case scenario with this. Anyone who has severe psychiatric illness or history of illness, addiction issues, changing or fluctuating mental status. And this is really, really important, particularly for us because we work in hospice. About 78% of people experience delirium at end of life. And so we go and we see our patients, well, they may be experiencing delirium. They may be agitated. They may be having hallucinations. They're certainly not oriented. So again, those type patients, or anytime their understanding is affected by culture, education, or language differences. So those are our at-risk patients. At-risk decisions certainly are when the patient is refusing recommended treatment. The other time is when they're unwilling or unable to kind of discuss their reasons for refusal. So if they just say, nope, I'm not doing it, I need to draw out a little bit more information. You know, the patient who says, I don't want chemo, I want to go home and be with my family because, you know, it's painful and I don't feel well. And then me following up and saying, well, what's the doctor say if you don't get the treatment? And having them kind of work through how they came up with their decision to say no to the proposed or recommended treatment. Or those patients who are hasty to sign those consents. I don't want to hear about anything, and where do I sign? Again, that's fine. Our patients do have the right not to hear all that information, but if I can't share it with them, who can I share it with? So we're making sure that we get informed consent for whatever procedure and go over the risk and benefits. So myth number 4, a decision-making capacity is an all or nothing phenomenon. And the fact that a patient may lack one of the components doesn't necessarily mean they don't have the ability to make their decisions. And this is what's so complicated about it. And there's so many intricacies with decision-making capacity. Certainly, you know, again, you're looking at the risks versus the benefits and so on with this. So it's very, very complicated. Even a patient who's deemed incompetent still is allowed to participate in decision-making as able. We don't just kind of strip that all away. So I have the case example here, and I call her Mrs. Mild Dementia so that we all know where she is in her disease process. She unfortunately has a very horrific urinary tract infection, and she's in the hospital. And usually we don't go to the bedside and say, sign for an antibiotic, right? But we'd go in and say, you know, Mrs. Mild Dementia, your physician ordered antibiotic and it's going to make you feel better. And she nods her head and says, okay. And we're kind of comfortable with that. It's a very low burden procedure. The risks are very low, but the benefit is extremely high to cure that urinary tract infection that's causing problems. So I have the same exact patient now who is going to need a complex neurosurgical procedure. And I think I'd feel very different, right? Assessing her decision-making capacity. Is she going to be able to weigh the benefit versus the burden? This is a very high burden with a potentially poor outcome, and thinking about the quality of life. So even though it's the same patient and we're talking about decision-making capacity, you can see how the level of the decision and the benefit versus burden ratio, we're going to have to look at her a little bit differently on the decision-making process. So making good decisions, and again, going back to that risk versus benefit analysis, favorable, we are all like this one. High benefit, low risk, really, really good. Intermediate, we're kind of unclear on the benefit versus risk ratio. But again, you just saw an unfavorable, low potential benefit and very risky procedure. So we need to bring this into the whole process of assessing decision-making capacity. All right, myth number 5, cognitive impairment equals lack of decision-making capacity. And while decision-making capacity and cognitive ability are related, they're not exactly the same thing. Again, when we talk about decision-making capacity, we're looking at their ability to make their own healthcare decisions. When you're talking about cognitive abilities, it encompasses so many things, from attention to comprehension, to memory, to problem solving. So we may see a patient who lacks decision-making capacity score very high on those cognitive tests. Before I came to Seasons, I worked for a neurologist and I did cognitive testing. And then I may see somebody who I thought could, you know, who very well educated and very alert and oriented and I thought understood, well, they may not be able to work through the components of decision-making capacity. So again, cognitive impairment does not exactly equal lack of decision-making capacity. All right, so an interview. So we all, when we get to the bedside to meet a patient, we do kind of a brief mini mental on that patient. You know, who are you, where are you, that kind of thing. Assessing the level of orientation. And I recently added this section for everyone because I've had a lot of questions on orientation and decision making capacity. We're also assessing for depression or any history of mental illness. And then we're using the questions to assess the 4 decision-making capacity elements. So again, those elements, and I'm going to tell you 100 times, so you're going to remember this, ability to communicate those choices. So my yes or no, ability to understand the proposed treatments and alternatives. And we're going to look at questions for these elements. Ability to understand and appreciate the consequences of either accepting or declining the treatment. And then the ability to reason through it, how they came up with their decision. So orientation levels can be very confusing because we'll be told maybe this patient is alert and oriented, and we get there and maybe they're alert and oriented times 1 or 2. Well, that doesn't necessarily make them able to sign those consents. So I wanted to look at this a little bit. So you're going to see alert and oriented, and people use a whole bunch of different combinations. So you see A and O, or you see A and O, meaning alert, awake, and oriented. So you may see AAO. And then we usually follow it by a time. So you'll see it alert and oriented times 1, 2, 3, and now 4. When I went to nursing school, it was only 3. Now, 37 years later, it's 4. But that 4th is a way of kind of, you know, expressing where they are in this situation. So looking at this, alert and oriented times 1 means the patient knows his or her name and can recognize other people. Alert and oriented times 2, now you're oriented not only to who you are, but where you are. So they know their name and they know where they're at. Alert and oriented times 3, person, place, and time. And in addition to knowing their name, location, now they know the date and the day of the week and the season. Then they added this times 4, and it's alert to person, place, time, and the situation. So now they know all those other things, and then why they're there, why are they in the hospital, or why are they living in a certain place? So they're oriented to those, you know, 4. So again, when we look at somebody who's alert and oriented times 2, they know who they are and where they are, but they don't know what time it is. They don't know what's happening. It's unlikely that they may have that decision-making capacity to sign those consents for us. And certainly they probably can't read what's in front of them. And so it's risky having somebody sign you know, a healthcare power of attorney or some other document when they're only alert and oriented times 2. And I'm not a lawyer, I'm presenting from the medical side. So, but when I think of cognitively impaired patients or those patients with dementia, early stages of Alzheimer's dementia, I think we all know they have good days and they have bad days. And so they may wake up in the morning and be fresh. They may be alert and oriented times 3 or even 4. But as the day declines, and after taking some of their multiple medications, they're tired. And so what we may see in the afternoon is only alert and oriented times 2. And this happens to us all the time. So we have people like Linda out in the field as a hospice care consultant, and she would meet with the patient and our family, and the patient's alert and oriented times 3, times 4 in the morning, and they sign consents, you know, the patient signed consents, and the admission nurse comes comes out and you know what, now it's 4 o'clock in the afternoon, it's dark as midnight, and they don't know who they are or where they are. So our admission nurse will say, who signed this patient up? So we need to take a step back, make sure that we are, you know, going in line with the physician's determination of decision-making capacity. And it often helps more when the family is there and with us and supporting, you know, the decision to transition to hospice services. So ability to choose. So again, we need to make sure that our patients have been given the information about their condition before we can kind of assess their decision-making capacity. And that's really, really important. Levels of understanding kind of differ, but I will tell you, I've seen on a face sheet stage 4 metastatic cancer, and then I walk in and the patient says, well, I have a tumor. I'm not feeling like we're on the same page. So we really probably need to discuss it just a little bit more, maybe a care conference with the doctor and kind of have a discussion. But thinking about, you know, asking them what kind of medical option is best for you. Again, trying to elicit from them what they want to do. You've been given a couple choices, you know, which do you feel will meet your goals of care? So those kind of questions. Ability to understand relevant information. Again, understanding the benefits of the treatment that is being prescribed or recommended and looking at the odds that it will work. And then maybe the symptom burden, the benefit versus burden of that particular treatment and what the doctor is recommending. And talking about the side effects of some of those risky type treatments. And then what would happen if you don't have the treatment? And again, we find this a lot with our patient population. Well, the doctor said this and this. And well, how do you feel about that? Well, you know what? It's worth it not to come back to the hospital. And we hear that time and time again. Ability to appreciate the consequences. Again, diving a little bit more deeper about other treatments, or again, that understanding if nothing is done, what's going to happen if you do have the treatment? How are you going to feel? So appreciating the consequences. Ability to reason, and this is really important. What were you thinking about when you considered your decision? And were they balancing the benefit versus burden of the treatment? Or was someone pressuring them to come up with a certain decision? Did they feel pressured by the medical community? Did they feel some pressure from the family? Well, you know, and so we want to make sure that there was no pressure, that they are making their own decisions. Sometimes we ask who helps you with your decision making, you know, your decision making and that kind of thing. But again, to make sure they're not being pressured. All right, so I think it's time for a case study here, and I like to call this woman Mrs. End-stage renal disease. And this is a very heart-wrenching case that we had. It goes back, I want to say 3 or so years now. And I think back into my mind that statement from Supreme Court Justice Cardozo about every human being can do with his own body as we so desire. And so we had this patient. She had been involved in a motor vehicle accident, which left her paraplegic. And she had tremendous pain, multiple surgeries, well known to the local hospital. She was always in and out. She also happened to be an end-stage renal patient who was going for dialysis. And she went back and forth to the hospital. And when we became involved with her, she had been in the hospital, and the surgeons were recommending a very risky surgery. And with the surgery, they were doing it to hopefully alleviate some of her pain, but they couldn't guarantee that her pain would be relieved. They also could not guarantee that she would have use of her hands any longer, that she might potentially become a quadriplegic. She had said to us, you know what, I'm already laying in bed, I'm in all this pain, I'm looking at the ceiling, at least I can itch my nose at this point. And her social worker was just a wonderful advocate for her. And this particular patient wanted to stop her dialysis. She did not want to consent to this very risky procedure with a potentially very poor outcome. And she just wanted to allow for a natural death. And she was young, she was in her 40s. And we do see end-stage renal patients decide that they want to allow for a natural death and forego dialysis treatment. And she was told by her physician, and I'm not saying anything negative about physicians, and this story was told to me by her social worker, but she was told, no, you can't stop your dialysis. Why could she not stop dialysis? And that was what she wanted to do with her own body. So as the scenario goes along, the social worker continued to advocate for her because that was her decision. They had someone come in from psych and they did an evaluation, and they found her to be somewhat depressed, but she had been treated, obviously, with the motor vehicle accident, the paralysis, end-stage renal disease, and the pain, obviously, but felt that she was decisional and that she should be able to make her own healthcare decisions. So the social worker had pushed for a palliative consultation, and we are only allowed to see patients that we are called in on consult from the attending physician, and the attending physician said no, that he was managing the pain. And so the social worker pushed it up, and it kind of went back and forth, and they took it to committee, and they agreed that she could have a palliative consultation. So our doctor did go in. He went in 3 different times, 3 different days, and asked this patient the series of the questions. And she was able to answer everything, and the palliative physician felt that she had decision-making capacity. And so long story short, she was able to finally come on to hospice, and we were able to care for her, but it took a long time through the process of going through everything. And she did come on with us. It was very sad because she did live about 6 months with us. With our end-stage renal patients, we never know how much residual kidney function that they do actually have. So with this particular patient, she had considerable kidney function. And like I said, she lived with us for about 6 months. We never quote, the mean is 7 to 10 days typically, but we never quote those numbers because somebody will come on day 11 and say, but they're still alive. We just never know for sure. So, but it was quite a fight. And to this day, when I see the social worker, she just was amazing and stood by this particular patient as an advocate, and she still cries about this particular patient. So the 4 elements we're going to go over again and again. Lack of any single element, again, does not ensure that a patient lacks decision-making capacity. And patients with depression, again, we want to make sure that we are assessing and it's not, their mood's not clouded or by medication or whatever. So here is the checklist I use. So number 1, can the patient express a choice? So I circle yes or no. Can the patient demonstrate understanding? Yes or no. Can they demonstrate that rational reasoning? And are they able to demonstrate the appreciation? We're always concerned if the patient is in imminent or immediate danger to themselves. So this is the checklist I use, and I'll show you at the end on a case study how I use it. Documentation. So as I said, when our palliative clinician went in to see this patient, documentation was key. The attending physician should be documenting the questions and the answers. This helps in any type of litigation because it is a clinical decision. On this day, at this time, based on my clinical impression, and here are the questions and answers I use to come up with my judgment. So really, really important to have that documentation. Now, for us, we are working with the physicians and feeding them kind of the information that we assess or that we bring to the table with that. All right, myth number 6, lack of decision-making capacity is a permanent condition. And it's not always permanent. It can be very short-lived. Again, we want to step back. If we can step back and we have that time, like in a different situation, like hospice, we can step back from the bedside. If I go and I find that patient is delirious or they're coming out of anesthesia or they've just had pain medication or they're in excruciating pain or they're hypoxic. So all those things are they can be very, very reversible and transient. So can I delay that decision, delay that signing of consents, or does it have to be done right now? In which case I'm going to have to assess their decision-making capacity and talk to that attending physician to see if we should then whatever is decided, then we should go with the guardian or the surrogacy list for the signing. All right, this is the case of Michael. He's a 65-year-old man injured in a motor vehicle accident. There's no next of kin around. His blood pressure is low. He had a sonogram and he's got abdominal trauma. He needs to go to the emergency room immediately. He has a liver laceration and he needs a splenectomy. He also has a traumatic brain injury. In this case, when somebody comes into the emergency room in this state of emergency, unless there's some documentation right there, we have what's called presumed consent, where we choose to save that life. It is, beneficial, and the default is always to saving a life. In this situation, certainly there would not be any documentation there available. All right, so patients who have not been given relevant and consistent information lack decision-making capacity. Definitely a myth. If I, again, have not provided relevant information on their condition and on their choices, I cannot expect anybody to have decision-making capacity, because we can't even go there before we really know that the patient's been giving the information. If you're not giving them any information, how do we expect them to make a decision? So we have to make sure those things are in place. And sometimes we see that they're really not understanding, or maybe it hasn't been said in the vocabulary that they need to hear it in. So we want to make sure that we're giving that information. There's something called Doctrine of Informed Consent. And again, that's disclosure of the pertinent information and then assessment of that decision-making capacity. And then is it voluntary? And that's really important. Free and genuine choice made without coercion. So, we want to make sure that they weren't pushed to this determination by anyone else, but they really do need to be informed. All right, myth number 8. All patients with certain types of psychiatric disorders lack decision-making capacity. And certainly that is not true. I've got a second part to this, so we'll go on to the second part. Patients who have been involuntarily committed lack decision-making capacity. I think in most of the states, patients can be involuntarily committed for mental illness because they're a danger to themselves or others. But even those patients aren't stripped of all their decision-making capacity. It's assessed, and they can participate in those decisions to the extent that they're able. So that's really important. Myth number 10, really important as well. Only mental health experts can assess for decision-making capacity. Again, my primary care physician has the right to assess for my decision-making capacity. And if they've known us and they've seen us, they know our history, they know our values, our cultures, our religious beliefs and goals. So they themselves can make that determination. What we see a lot of times is the default to psychiatric consultation. And it's not necessary, except for in cases where maybe there is a history of mental illness or maybe significant depression. So more in those specialty type cases. Otherwise, the primary care can do that. But what we see is kind of the default to the psychiatric evaluation. I think sometimes protection for litigation, right? Calling that other expert in to assess. Now, have we seen the primary care physician and the psychiatric consult differ? Yes, we have. And again, we have the ability to step back and let them decide, and then we can proceed. We do see Jerry Psych or bioethics panel for cases that are very unusual or there's a lot of conflict, particularly with the family involvement. So I have one more case study here, and I want you to think about this poor patient. Was she decisional or never decisional? Was she competent or never competent? Did she have decision-making capacity? This wasn't a patient of ours. I took this from the literature, but I felt it really was a very powerful case example. So I have Wendy. She's only 35. She was diagnosed with obstructing adenocarcinoma, which required a partial colectomy, no evidence of metastatic disease at that time. Post-operatively, before she even left the hospital, she developed these fistulas, which caused seepage of feces, chronic urinary tract infections, and pain. Wendy had a history of being chronically depressed. She was living alone. She was unable to support herself and had minimal family support, and also had a methadone habit. Post-operatively, she neglected all of her appointments. So 2 years have gone by. Wendy presents to the same hospital, to the ER with shortness of breath. The chest x-ray showed pulmonary infiltrates, and it was suspicious for metastatic cancer. Now, Wendy in the emergency room refused any further workup or treatment, but she was transferred to the intensive care unit. The patient somehow, some way from the intensive care unit gets a phone, and she calls hospice. She is asking for hospice care. The only thing I can think of is some angel gave her that phone who knew about hospice to have her call. Wendy starts to decline and she becomes obtunded. She's diagnosed with a new acute leukemia. Now her two daughters arrive, and they must be very young given her age, and they agree to a rapid induction of chemotherapy. They want aggressive treatment to save their mother. So as this scenario goes on, her condition then improves. And once again, since she's improved, she's got the phone again. She's calling the hospice. She's saying she's bleeding from her nose and mouth, and she doesn't want to be in the hospital anymore. So Wendy is essentially asking for admission. Wendy says her oncologist will not allow her to leave the hospital. He said he was going to get a psychiatric consultation to declare her incompetent. So here's what we know. Wendy has a terminal disease with a poor prognosis. We know this. She did not, from the time she hit the emergency room, she didn't want any aggressive treatment. She just wanted to go home. We do know she has a history of poor choices, maybe judgment. She hadn't followed up. The hospice physician ended up calling the oncologist, and the oncologist said the patient had gone out of her mind and it would be inconceivable to stop the chemotherapy, which would be tantamount to suicide. The oncologist stated he would not certify the patient for hospice services. So the next thing the physician does is write a psychiatric consultation, and a visit is made to Wendy. And what did Wendy do? Because Wendy was feeling like she was okay, she refused to speak to that psychiatric consult. So somehow, some way, where she was, and I don't think it was revealed, certainly in the case scenario that was the one I got this from, wherever she was, they wrote orders to transfer her to a locked psychiatric ward. And this is certainly, I think we just all gasp, and it's a violation of her human rights. But anyway, she was kept there in the unit for the weekend. And Monday morning, the oncologist comes in, and Wendy then agrees she'll take whatever kind of treatment, just as long as she can get out of that unit. Now the daughters are no longer around anywhere, and the hospital has no choice but to pursue a legal guardian. And sadly, Wendy dies in the ICU, having spent the last 4 weeks of her life in the hospital. So when I look at this from a decision-making capacity perspective, I think when Wendy got to the emergency room, had someone intervened and assessed for her decision-making capacity and guided this in a different direction, I think this would have turned out very differently. I think you have to ask yourself, what was her life expectancy with this metastatic process? And then with the acute leukemia on top of it. And it's heart-wrenching from a hospice perspective, because I think we could have cared for Wendy at home in comfort instead of having her die in the ICU after 4 weeks. All right, so here's where, this is the last thing I want to share, the case example of how I use my format to assess for decision-making capacity. So I have two patients, patient A and patient B. They're both 78 years old. They both live alone. They both have a history of falling. They're on Coumadin because they've both had a recent CVA. They're both deconditioned. They need OT and PT because they cannot even do their own ADLs at this point as a result of the stroke. Likely both will benefit from rehab, and both patients are refusing. So you can see they're absolutely identical. All right, so here's where we go to choice. Both of the patients, A and B, they both want to go home. But here's where I look at the understanding. So when I talk to patient A and try to assess so I had my choice, choice from the patient, now understanding. This patient tells me, you know what, I know the nursing home staff can help me if I fall, and the goal of rehab is to make me stronger. Now patient B starts to differ a little bit, where patient B says a nursing home is for folks that can't take care of themselves. Then I go to appreciation. Patient A is applying this to their own situation. If I fall, I'm on Coumadin, and I know if I fall, I could lay there and bleed to death. Patient number 2 says, or patient B, I don't fall. Why would I fall? Why would I bleed to death? I'm not going to fall. And they both have a history of falls. Rational reasoning. Patient A then goes on to tell me that they've had a horrific experience previously in a nursing home, and they are never going back. They're going home, period. Patient B says, I don't need it. I can take care of myself. So you start to see when I write this down how it differs. So again, both of them can state a choice. Both kind of demonstrate general understanding. But patient A has that appreciation, has that rational reasoning. I believe he does have decision-making capacity. I don't like his choice because I think he's going to fail that home plan, but I can't make him go to that nursing home. All I can do is support him. So with home health, maybe an alarm bracelet, try to find friends or family who can kind of check into him, or a neighbor. I don't like his choice, but I can't force him to the nursing home. Patient B, I'm really concerned about because he does not demonstrate appreciation to his own situation. I don't feel he has that rational reasoning, and I do feel he lacks capacity. So in my mind, but again, it is a decision from the attending physician. But in this scenario, you know what? I think they're probably, because there are no family or friends per se, we may have to pursue guardianship because that is not going to be a safe discharge plan. So hopefully if you use that, it'll help a little bit to, you know, look at the decision-making capacity. One last thing, there's something called curves, and you do see some literature on this for emergency decision-making, and it stands for choose and communicate, understand, reason, value, emergency, and surrogate. So when I look at this, you know, can they choose the same thing? Can they understand? Can they reason through it? Is it consistent with their value system? And if the questions are no or unclear, it's unlikely that they have decision-making capacity. And then they start to look, is it an emergency? Is there risk to life and limb? Or is there a surrogate around? Otherwise, it's up to the physician. So best practices. So for those who have cognitive status that it's unclear or it's fluctuating, we need to protect them from two mistakes. Number one, preventing capacitated patients from directing the course of their own healthcare, and then failing to protect incapacitated patients from the harmful effects of their decisions. So with that, we are at questions. I think we are at 12:57 according to my clock. So Lauren, were there any questions that came in that I can answer?
Oops. Hello. No, you know, we haven't gotten any questions in. We did get a good comment from Maureen when you were going through the cases, just explaining, she thought that Wendy's case was an outrageous violation of her rights and
Yes.
malpractice. And I think that you've had some really good dialogue here, walking through the examples and really thinking about what's best for the patient or the client. Does anyone have questions? I can open up the floor on the chat, of course, or you're welcome to unmute yourselves at this time if you want to ask a question out loud. So take it away, anyone that wants to ask a question. Well, you must have just been really thorough.
I guess so. It's all there. So if anybody who wants CE could email me, it's Hoekstra@seasons.org. Like I said, I do have your emails from the RSVP list, but email me directly, and that way I can send you a copy of the PowerPoint. There's an additional handout I have entitled Assessing Decision-Making Capacity in Intoxicated Patients from Medscape from 2017. I thought you would be interesting. There is an activity eval and that I can send you. And once you complete that, I will send you your CE certificate. For any family members, even if you don't need a CE, if you'd like a copy of the PowerPoint presentation, feel free to email me.
Perfect. And Ellen's email is in the header or the CC line of the email I sent this morning as a reminder, in addition to the chat box right now. And of course, Ellen will have your emails to follow up likewise, but thank you all so much for attending today. We'll get you your CE credits, and take care and happy holidays to everyone. Thank you all.
Thank you, Lauren. Thanks everybody for joining us today.